everyone. Welcome again. Well, everyone, look where we're at. It's another expert talk series, and your extended family has all come together. And it's a very special time of the year. So I'd like to ask a little favor of you. Giving comes in so many ways. And one of the ways that you might be able to give something to all of the people in the ALS community is to join our speech program. It's pretty simple. It's like 75 minutes over 5 months. So 15 minutes a month just reading for us would make a huge difference. And if you have ALS, if you're a caregiver or healthy or someone with probable ALS, we would love for you to contact us and become part of the team. And with that, welcome to every one of you. Welcome to your extended family and to the holidays. And with that, I'll turn this over to Indu Navar, our CEO and founder of Everything ALS.
Thank you, McFinn, and welcome everybody. And this would be how we conclude our 2024. And what a great way by inviting Cathy Hoerth, MD, PhD, is a full professor of neurology at UCSF and have significant experience in ALS clinical trials. She's been a PI of many clinical trials and also has received NIH and ALS Association's grants to study ALS predictors of prognosis, environmental risk factors, imaging abnormalities in ALS and PLS, and also efficacy of intrathecal baclofen pump treatment for PLS, and also overlap with ALS and frontotemporal dementia. Cathy follows over 375 people with ALS and with 100 new referrals in ALS Multidisciplinary Center at the UCSF, which includes speech pathology, dietitian, social work, physical therapy, occupational therapy, respiratory therapy, nurse, and neurologists as a center, and trained under Dr. Richard Olney. Now Cathy took over as a director of ALS Center in 2004 when he retired. And with no further ado, I would love to invite Dr. Cathy Hoerth to actually, give us the presentation.
Thank you so much for inviting me. I look forward to being here. I recognize several names on the call, so thank you. I'm just going to share my screen and then get started. So I'm going to talk today about how we care for ALS patients, and also we'll focus towards the end about caring for ALS patients who have cognitive difficulties or behavioral issues. And so just to start, what do we know about ALS today? We know it is a universally fatal disease. We know that the mean survival after the first symptom is often on average 3 to 5 years, although some patients can die 2 months after their first symptom, and others are still walking and doing well 10 years after their first symptom. It is the most common adult onset motor nerve disease, and we still don't understand its pathology. We don't understand a lot about what causes the disease. We also know the disease is very heterogeneous. Every ALS patient is unique as far as what their experiences are and how their clinical presentation. Patients can vary in their rate of progression, what regions are affected during the disease course, whether or not they have a family history of a degenerative disease like ALS or Parkinson's or Alzheimer's disease, and trying to accurately categorize patients into different categories is really of utmost importance in terms of helping us with our research into targeted therapies. And a key aspect of the disease is also the variability in terms of cognitive and behavioral involvement, including frontotemporal dementia. So what is frontotemporal dementia? If you haven't heard of this before, it's one of the rarer dementias. It's where there is selective degeneration and atrophy in the front part and in the temporal lobes of the brain. Patients can present with personality changes, language difficulty, or behavioral disturbances. It is progressive and irreversible. It is not a particularly higher risk in pseudobulbar patients, which is one of the earlier theories. And there are very clear criteria that were originally established by NERI in 1998 to describe this dementia. It's very different from Alzheimer's disease. There are three main presentations. One is a behavioral presentation where patients often have issues with organization, executive functioning. They might have poor insight into their disease. They may be apathetic or disinhibited, may have decreased speech output. And then for the temporal variant, patients will have issues around comprehending words, more significant word finding problems, but good insight into what's going on. And then the progressive non-fluent variant is where speech is very hard, not because of a motor problem, but more because of the brain, the connection between the brain and the speech being affected. Patients might have grammatical errors, but they have good comprehension. So we know there's a genetic overlap between ALS and frontotemporal dementia. About 10% of ALS is familial, but about 40% of frontotemporal dementia is. And when patients have ALS and frontotemporal dementia, affected family members might have ALS alone, they might have frontotemporal dementia alone, or both, and suggesting a relationship in the pathogenesis of these disorders. And the questions we wanted to ask in our research is, do ALS and frontotemporal dementia overlap when there's not a family history? And is there a spectrum between pure ALS, cognitively normal, and patients who have ALS and dementia? And I'll answer those questions a little later in the talk. But now I wanted to turn to another point, and that is environmental risk factors. So there are risk factors for the disease. For decades, dementia has been known to be associated with boxing. Trauma is associated with Alzheimer's disease, frontotemporal dementia, ALS, and Parkinsonism. And typically, the pathology that is found is TDP-43 and tau. There's an increased frequency of degenerative disease and trauma-causing professions. Soccer players are at greater risk. NFL players are also more likely to get ALS. And military veterans are twice as likely to get ALS, and it's higher in deployed versus non-deployed veterans. And I wanted to make a point here. If anyone has ever served as a veteran, there are amazing benefits through the VA, including a wonderful pension and much financial support. So if anyone's a veteran on the call, I encourage you to become registered at your local VA hospital and get connected to a VA ALS clinic. Okay. So I think most people on the call know what ALS is, but just to briefly review, it's a combination of upper motor neuron damage and lower motor neuron damage. In this picture, the upper motor neurons are shown in the dashed lines, and the lower motor neurons are shown in the solid lines. Upper motor neuron damage causes slow speech, brisk reflexes, as well as stiffness or spasticity. And the lower motor neuron findings are atrophy, fasciculations or twitching of the muscles, and weakness. We use an EMG to help diagnose lower motor neuron findings, and our clinical exam diagnoses upper motor neuron findings. But this combination is very unique. There really are not other diseases that cause damage to both of these types of nerves, except in rare cases of a structural lesion like a brain tumor or something. And these are the things that can mimic ALS, and these are very important to exclude when making a diagnosis, making sure there's nothing structural going on to cause a pinched nerve or someone with a tumor. Post-polio, people in this country, if they're older, sometimes didn't have access or the polio vaccine wasn't available, and so the people can sometimes develop a progressive weakness later in life if they had polio when they were younger. There's something called multifocal motor neuropathy that we want to exclude, various endocrine problems, lead intoxication, very rare in this country, and then certain infections like Lyme disease or HIV or AIDS, and then sometimes lymphoma or a monoclonal gammopathy can look like ALS. So when a neurologist is first seeing a patient, typically they will go through and make sure that the patient doesn't have one of these other things, because we don't have a blood test or something that we can point to on an MRI to say, oh, that helps to make the diagnosis of ALS. It's a clinical diagnosis. And so to treat it, it's been very complicated because there's lots of things that are damaged in ALS, shown in this slide. Problems with the transport along the nerve, problems with not only the nerve, but the microglia, the astrocyte. And then I'll talk later about a particular genetic form of ALS called SOD1, where there are aggregates that form and cause nerve damage. And so over the years, various therapies have been tried and are continuing to be tried in ALS, targeting these various pathways, since we really don't know what the chicken and the egg is. What is the thing that triggers all of this cascade of problems to start? So we currently have 4 FDA-approved drugs for ALS. Riluzole was approved back in 1993. It attacks glutamate, which is a toxic chemical released from a cell that's dying. Nuedexta is called an NMDA antagonist. This was FDA approved in 2011 for pseudobulbar affect. That's easy laughing and crying. And it may also help improve speaking and swallowing, at least temporarily. So we often will prescribe it if someone is having issues with easy laughing and crying, or if they're having issues speaking and swallowing, we usually trial this medicine and see if it helps with that. Edaravone or Radicava is a free radical scavenger, and this was FDA approved in 2017 to treat ALS. And then tofersen is an antisense oligonucleotide. It's a genetic therapy, and this was approved in 2023 to treat SOD1 patients with SOD1 ALS, which is 1% of all ALS. I should also mention that for all ALS patients, genetic testing is free. And so you can ask your doctor if you could have this free genetic testing just to check and see if you might have a gene abnormality that might make you eligible if you happen to have the SOD1 form to try this new treatment. And other treatments are in development for genetic forms of ALS. I mentioned Edaravone Radicava, and this treatment was initially not shown to be effective in treating ALS. It was tested in Japan, but then a subgroup analysis showed there was a benefit in patients who were earlier on in their disease course. And this was confirmed by a larger study in Japanese patients. And so in August of 2016, the FDA accepted a new drug application for Edaravone, and it was approved and released to the US market in August of 2017. In 2022, the FDA approved an oral form. So initially it was needed to be given intravenously in the home or in an infusion center. But an oral form was approved in 2022 based on a safety study. And then it was tested further in Europe with the ADORA study. And unfortunately, it did not work in this larger study in Europe. However, there were some differences. The dose was slightly different, and the medication was given every day. With if for anyone on Edaravone, you know that the recommendation is that you take it 10 days out of the month and then have a break. So the company feels that it's still, and the FDA has decided to continue recommending Edaravone, and insurance is still covering this medication, even though the European study was negative, feeling that there were some differences in the way the study was conducted that may be the reason why it was negative in Europe. And then tofersen is, I mentioned, is genetic therapy, a gene therapy for SOD1 ALS, and it was shown to, that this drug was shown to reduce the levels of this protein by 35% in just 8 weeks, and then also neurofilament light chain levels were reduced. That's a marker of nerve degeneration. That was reduced by 50%. When it was started earlier, it seemed to work better, and so there's currently a trial ongoing for people who have the gene mutation but have not developed symptoms of ALS to see if this helps. It's very important to make sure not only to find a ALS certified center, either certified by the ALS Association or the Muscular Dystrophy Association, to confirm the diagnosis, because there's many things that can look like ALS. And also it's important to keep tabs on what opportunities are available for clinical trials. And you can do that both with the MDA Clinical Trial Finder as well as the NIH Clinical Trial site. You just have to, on clinicaltrials.gov, type in ALS, and you can look at all the current trials that are happening, or if you happen to hear about a new therapy, you can check to see if a site is enrolling near you by going to this site, typing in ALS, and then typing in the name of the drug that you've heard about that you might be interested. Okay. There are many treatable symptoms in ALS, and we focus on treating all of these things from head to toe in our multidisciplinary clinic. And I'll briefly go through this because I wanted to spend most of the time on focusing on the cognitive overlap with ALS, but nutrition is an issue in ALS, both for those who have swallowing issues, those who have arm weakness, trouble accessing food. Shortness of breath can cause increased energy expenditure, and all of these things cause difficulty getting enough nutrition. And there are many solutions: breathing aids, eating aids like the OB device. It's a device that can feed patients. We focus on a high protein, high calorie diet. Often recommend food consistency modifications. Foods that are soft and moist are easier to eat. Liquids that are thicker. There's Thicket that you can buy in the grocery store to thicken your liquids. And then eventually a feeding tube is often recommended to supplement what people are taking in orally so that they can be well hydrated and have good nutrition. And it's always this balance in terms of eating, between comfort and safety, as well as supporting weight and maintenance and hydration. And so it's often a conversation that we have over a series of courses of weeks or months to make sure that we are recommending something that fits well with the patient and what their goals are. As far as breathing, this is typically the reason why ALS patients pass away from the disease. It's usually breathing failure as opposed to a fall or some other type of condition causing death. Infections are fairly rare with ALS, but breathing it happens with ALS because of diaphragm weakness and chest muscle weakness, as well as increased energy expenditure can put a lot of pressure on breathing. And so there's some very good non-invasive equipment that can help with supporting breathing. Cough assist machine can help with expanding the lungs and removing secretions. Diaphragm stimulation was initially thought to be promising in ALS, but was shown not to be effective, and so we don't recommend that anymore. And then invasive ventilation is something that is chosen by about 1% of patients with ALS. There are some challenges when having invasive ventilation because it does require 24-hour care, and that can be difficult to pay for since it's often not covered by insurance, the caregiving. And so breathing equipment can help with many symptoms: daytime fatigue, shortness of breath, cognitive issues, morning headaches, as well as helping with speech. So we like to start the equipment very early. Cramps can be managed with a variety of medications, as well as things like massage, hot baths, stretching, many ways to treat cramps. And then spasticity, it's always a balance between being too stiff or too loose. If you're too loose, then patients can feel weak and be more vulnerable to falling. If you're too stiff, it can be hard to move quickly and can be uncomfortable. And so there are a variety of medications we use to help treat spasticity. If patients have a lot of side effects as far as sleepiness, we'll often recommend a baclofen pump that provides the baclofen straight into the spinal fluid to help improve spasticity. And then Botox is a treatment that we often recommend for excess saliva, but can also help for very focal spasticity. Speaking of excess saliva, we have good medication that helps to dry up that saliva. Radiation treatment can also be effective, and then Botox as well to the saliva glands to basically decrease the saliva production. It's not that someone is producing more saliva than normal with the disease, it's just that with swallowing less and swallowing becoming more difficult, the saliva accumulates. And then thick saliva can be a big problem, and so taking guaifenesin or Robitussin, Mucinex, those medications can help thin the saliva, as well as papaya enzyme, or just eating pineapple or drinking pineapple juice. They're enzymes in the fruit that really help thin the saliva. Increasing fluids is important, and then some other treatments like hypertonic saline or Mucomist can help, and then a cough assist machine and suction machine can help get rid of that thick saliva. I mentioned easy laughing and crying, and that's something that was really hard to diagnose until we had a scale, and we use this scale in clinic whenever patients have any symptoms of easy laughing and crying to try to quantitate that symptom and see how they respond to treatment. Amitriptyline or Elavil can definitely help, but this drug Nuedexta that was approved in 2011 is quite miraculous as far as really resolving this symptom typically, and can also anecdotally help to improve speaking or swallowing. It's available from a compounding pharmacy if there are insurance issues covering Nuedexta or if the copay is too high. At a compounding pharmacy, we use one in the San Diego compounding pharmacy, and it's $150 for a 3-month supply, so not too bad. This is the scale I was mentioning that we usually run through with patients in our clinic if they are having any issues with easy laughing and crying. And there are 4 questions around laughter and then 3 questions around crying. And there's a sliding scale where patients rate how frequently they struggle with this symptom, but very easily treated. And this just shows the benefit of the medication. With the medication, the dose that was FDA approved is shown in black, and then in white is the placebo, and this is the proportion of days that people were episode free or in remission, and so it's quite effective drug. Urinary urgency, the need to go to the bathroom more frequently, is a common problem with this disease, and so there are things that can be medications that can be used to help with that. Condom catheters, there's suprapubic catheters, and then male and female urinals, as well as something called PureWick, which is kind of like a vacuum cleaner that's designed specifically for removing urine, and that can be quite effective as well. Depression can be a big problem with this disease, and we certainly want to make sure that it's not related to nutrition or respiration or sleep. But if those things are optimized and someone's feeling depressed, a counselor can often help. Talking to someone in palliative care can help, and then we will often start antidepressants as well. Sleep can be an issue in ALS, and a lot of times that's because of mechanical issues or lack of breathing support. And so resolving those things are important to do first, and then start treatment with medication. We often start with just something simple like melatonin, and then consider sedating antidepressants such as mirtazapine or Remeron that can also help with appetite and mood as well as sleep. And then lastly, the benzodiazepines can be helpful and can help with spasticity as well. Constipation can often be managed by increasing fluids or fibers. Fiber, considering stool softeners, lactulose or Miralax can help as well. And then there's specific new medications for constipation that results from narcotic use. So for patients in hospice where constipation can be more of a problem if they're taking narcotics to help their shortness of breath, there's new medications like Linzess that can help target that specific constipation from narcotics use. And then there's a lot we can do to help optimize weakness these days. And we really try to anticipate equipment needs in the clinic so that people can get equipment before they absolutely need it. And we do recommend exercising for muscles that are mildly weak, stretching for everyone, and then thinking about some light aerobic exercise. And we talk a lot about energy conservation as well. You can often get free ergonomic evaluations at work that can help with as patients become weaker. If they are enjoying work and want to continue working, then they can still do that. Although for ALS, I think many of you are probably aware that you're instantly eligible for Medicare and Social Security disability with the disease, no matter what age you are. So that's a nice, unique benefit of the ALS diagnosis. I'm going to just kind of skip through this. There's just been a lot of advances with equipment, and I mentioned exercise is important to consider. Lots of advances as far as speech language pathology in ALS and options for communication. And then with end of life, many institutions now have palliative care programs that help from the time of diagnosis until the time of enrollment in hospice to help with the disease, coping with the disease and managing symptoms. And so that all that's can really help to support the disease. So in the last few minutes, I do want to say a few words about this overlap with cognition and behavior issues. So we did a study that found that in patients with frontotemporal dementia, about 30% of them had signs of definite or possible ALS when we examined them with EMG in a clinical exam. And about 50% of ALS patients had some sort of executive function deficit. Initially, there were 4 clinical subtypes identified: those with ALS and cognitive impairment, those with ALS and behavioral impairment, and those who met criteria for frontotemporal dementia. These days, I think the typical term is just FTD spectrum disorder, just to refer that there can be a really big spectrum, from someone who's just having the slightest word finding problems to someone who cannot speak at all because of dementia, not because of motor issues. So there's a huge range of severity. And this just reiterates what I told you, that in our cohort at UCSF, we found about half of people were completely cognitively and behaviorally normal. Around 20% had dementia, frontotemporal dementia, and then a smaller proportion had either mild executive dysfunction or behavioral dysfunction. And this just shows that there are correlates on the MRI as well. So that in red are the areas of atrophy, and in column B are those patients who are completely cognitively normal on neuropsychological testing. And then in A are those who had ALS and had abnormalities on the neuropsychological testing. And you can just see there's more brain atrophy in those patients who scored abnormally on the neuropsychological testing. I mentioned earlier that TDP43 is the main protein found in ALS, and it's also the same protein that's found in FTD. And mutations in TDP43 cause both ALS and FTD. And then another protein was found in 2011, a very important genetic cause for both ALS and frontotemporal dementia, and that's C9orf72. And it's responsible for almost half of familial ALS cases and about 12% of FTD cases. And then sometimes even sporadic cases can have mutations in this gene, which is there currently is an antisense oligonucleotide treatment that will be in clinical trials soon for the patients with this gene abnormality. And I think whenever we talk about having a patient having some cognitive or behavioral issues, I think it's very important to think about, is it really dementia or is it coping? Because this is a difficult disease to adjust to. And sometimes people can become withdrawn because they're depressed or want to seek control in some area of their life, or they might have anger outbursts due to frustration of the disease or be in denial. And so those types of symptoms are quite different than those who have FTD. People who have these FTD behaviors, they're apathetic, they may be disinhibited, they may have poor judgment, they may be easily frustrated by small things, not things that are related necessarily to the disease, and they may have a lack of insight into what's going on, as well as having some language difficulties. So with neuropsychological testing and an expert evaluator, it's easy to distinguish from coping versus actually a condition. And we have to be very careful to exclude, mimics of someone who actually has depression or someone who's having issues with their oxygen level impacting their ability to think clearly. So that's important as well. But we did find that even this very mild form of the frontotemporal dementia did have a clinical significance. The survival was shorter and compliance with recommendations was less with this condition. And others have confirmed this as well, this survival difference. And patients were not as compliant with the feeding tube and the non-invasive ventilation recommendations as well. And so in closing, I wanted to say that there are important clinical issues for ALS patients when they have cognitive or behavioral impairments. The survival rate is shorter. Compliance can often be an issue. It can be distressing for the caregiver if the patient is having issues with being in denial about their condition. There can be poor safety awareness with falls or choking. It can be challenging for these patients to manage important decisions. And there's implications for certain therapies like stem cell therapy, where patients may you may fix some of the strength issues, but maybe not what's going on higher up in the brain. And it can impact communication options. Sometimes it's hard for patients to be able to use a communication, like a computer communication device. And so we know that we have medications to treat many of the symptoms of ALS, and many medications are in clinical trials to try to move the field forward and have better treatments to slow down the disease further or potentially reverse weakness. Equipment advances are moving forward, particularly around the brain-computer interface and communication options. And then multidisciplinary clinics do a lot to help improve have been shown in research to improve both quality of life as well as prolonged survival. So it's important to be connected to a multidisciplinary clinic. And then it's important to be aware of any cognitive or behavioral impairments because they can impact survival and management. And I just wanted to acknowledge the multidisciplinary team members that I work with. I just could not work in this field without working with this team of people that are so amazing. And then this is our actual team at UCSF doing the Ice Bucket Challenge a few years ago. So thank you so much, and I'm happy to take questions.
Thank you, Cathy. That was excellent, summary of everything you have done from your experience. And we have a few questions here. And the first question would be, is it true that people diagnosed with ALS are more likely to have suffered concussion in a decade prior to diagnosis?
Yes, there is some correlation between having some sort of trauma, whether it be a car accident or concussion and developing ALS. But many people have concussions. I've had one myself, and don't develop ALS. So it's not a direct correlation, but I think it's thought to be a potential risk factor. That's a great question.
Thank you.
This is a two-part question. Are there specific types of brain scans beyond a basic MRI that can help identify what type of dementia someone has? And would brain scans look different for someone that has C9? And what about someone who has sporadic FTD?
Yeah, that's a great question. And on the standard MRI, if the condition is severe enough, it absolutely will show up as atrophy, and it does look pretty much identical between whether it's C9 or sporadic FTD. You can see the atrophy in the frontal and temporal lobes, but researchers are doing a lot of more specialized imaging. And so I would imagine if you're followed an academic medical center, probably the memory and aging group at that center is doing research like they are at ours, and you can get research MRIs and contribute to the research in that way. And at least at our institution, they take patients who are cognitively normal as well as those that are not, so to be able to better capture the full range of abnormalities on the MRI.
Thank you. And the next question is regarding genetic testing. There's familial genetic testing for ALS. Is there a similar one for FTD other than C9?
Yes, there are several different gene abnormalities that cause FTD, and so it's possible to get commercial testing. It's just not free. So the nice thing is with the ALS testing, it's all free, but the only gene that the ALS panel checks is C9orf72. But you can absolutely see in a memory and aging clinic, you can get the full FTD screen for gene abnormalities.
Another question we have is, do you detect lead in your body using a blood test or urine test using DMSA?
We just use blood because the amount of lead that you would have to have in your body in order to actually cause something that would look like ALS has to be really, really high. Like you have to be working in a factory that's working significantly with lead. So we do just use blood because we feel that if that were the cause, it would have to be pretty high levels, and we would be able to detect it in the blood.
Great. There was a question on when you talked about spasticity. What is focal spasticity?
So sometimes patients can have, they're taking baclofen, which is helping to relax most of the muscles, but sometimes they have muscles that are just not responding very well to that treatment. In particular, it's often the adductor muscles, the muscles pulling the legs in. So sometimes people have what's called a scissoring walk, where their feet cross like this. And so if you give Botox to the adductors high up, then it can keep those feet a little bit more separated so that it's easier to walk safely.
Another
It's
question
something usually done in a movement disorder clinic.
Thank you.
Another question is regarding saliva accumulation. Would papaya extract and pineapple beneficial in reducing saliva buildup because of the effect of physically swallowing those, or is this something that could be used in a G-tube?
It is the effect of physically swallowing it, and it's not to reduce saliva, it's to thin it. And so basically the enzyme, it's a local enzyme. So you could probably try to swish it in your mouth, some pineapple juice, and perhaps it would have an effect, but yeah, putting it in the G-tube doesn't necessarily help. But for a drug that's more systemic, like Robitussin or Mucinex, if you put it in the G-tube, it should help to thin saliva.
Thank you, Cathy. So the next question was, is a low dose of SSRI helpful for constipation?
Well, it is true that SSRIs do often cause diarrhea. And so if someone's having constipation, then it may help. But we don't usually use it as a first line for constipation. We tend to use the medicines that are designed to treat constipation specifically, most of which are over the counter, things like Colace, Miralax, Senna, things like that.
Thank you. Does FTD speed up the life expectancy of ALS?
Yes, it decreases survival with a formal diagnosis of FTD, or even some of the more mild impairment. Patients often die 1 year earlier. So it definitely does speed things up.
Wow. So there's a question on stem cell. Can you touch a little bit more on the stem cell therapy for strength? You said muscle
Sure,
strength.
yeah, definitely. There's a couple of so I'd like to talk about two things. One is at Cedars-Sinai Medical Center in California, in Los Angeles. Researchers are doing an interesting study where they're directly implanting stem cells into the brain. And what we know from that study so far, I was attending the International ALS meeting virtually last week. And in that meeting, or 2 weeks ago now, the researcher Clive Svensson mentioned that they have data that those stem cells survive up to 4 years, potentially, longer. And the study so far has been very safe without side effects. 6 patients have been enrolled so far, and they will enroll people from around the country if you're willing to travel to Los Angeles. So it can be worth looking up on clinicaltrials.gov or just going to the Cedars-Sinai website. So that's one stem cell trial that's in place. And the goal is with those stem cells is to basically create a healthier environment for the cells that are dying to help to keep them alive longer. So not necessarily at this point designed to improve strength, but hoping to slow things down. And then a similar trial that will be starting this later this winter is the Brainstorm stem cell trial, which there was a trial before that was a smaller trial that was not positive and was not approved by the FDA, but for patients who were earlier on in the disease process, the stem cells worked really well, and some patients even did get better temporarily. And so that's a treatment that will be starting, again, a larger trial in the winter from Brainstorm. I don't know if that answered your question.
Yeah, no, thank you. That answered. And there was a follow-up question was that, is there any stem cell treatment to help with cognitive challenges?
Not yet. Not yet. Although you would think, because with Dr. Svensson's work, he showed that the cells do migrate somewhat. So it's possible that since he's planting them into the brain, that patients might have some improvements, or it might help slow cognitive decline.
Thank you. The next question is, are saccadic fixation abnormalities sufficient to separate cognitive from behavioral forms along the ALS FTD spectrum?
It's definitely one of the things we use. This is referring to an eye movement test. And so I think it's not, I wouldn't say it's diagnostic, but definitely a sign that makes us think about doing more testing. Yeah, good question.
And are there any promising therapies that are in trial right now for FTD and ALS from your point of view?
Yeah, so the with C9orf72, there's a very specific mutations, there's a very specific antisense oligo treatment that is being developed, and I imagine they'll be enrolling patients soon. I think that's probably the most promising. There have been some other completed trials that didn't necessarily work, but yes, there are no treatments for FTD at this time. But I think that's one potentially promising trial, and I think that anything that ends up working for ALS is typically then will be tested in FTD to see if it helps that, since the pathology is identical.
Do you have do you know of any effective trials for restoring function for someone with advanced ALS?
Not yet. I think that I'm sure we will get there over time, but right now the trials are aimed at slowing down the disease process. What I would say for people who are more advanced, though, is we have had so many amazing equipment advances that it's really worth connecting with an ALS clinic that would know the latest to see how, even though you may be having quite significant weakness, you may be able to be more functional with the appropriate equipment.
For diagnosis purposes, should patients also be getting an MRI if they haven't already?
Yes, so typically what we do in the diagnosis is MRI. You take an MRI of the region of the body that's affected. So if someone has hand weakness only, we would just MRI the neck. If someone has difficulty speaking or swallowing or a lot of stiffness on exam, we may also image the brain. And if someone has weakness more in their legs, we would typically image the lower part of the spine. So we image the part of the brain or spine that corresponds to where someone's symptoms are, and make sure there's not a structural lesion. But it is important to have some sort of imaging study as a part of the diagnostic workup.
So the next question is, what would you suggest for someone with a huge amount of mucus from the nose, not saliva issues?
Definitely see an ear, nose, and throat doctor. So sinus infections are so hard to treat. They can go on for months. Patients often can have nasal polyps or allergies. And in an ear, nose, and throat doctor's office, they will take a very small camera, look up right into your sinuses, and they'll be able to see everything going on, and will be able to treat you appropriately, whether that's with steroids or antibiotics or a combination of both. So I think it's very important to address. A simple over-the-counter thing you can do while you're waiting to get into the ENT doctor's office is Flonase, which is a nasal steroid spray, and it is over the counter, and you can try that while you're waiting for an appointment.
Some of the antisense oligotoids have allegedly made folks worse. You mentioned an upcoming trial. Do you know how it relates to past research?
So well, for example, with the tofersen trial, the patients, did get some people even got better with the treatment over enough time, and certainly did not get worse. So I think that at least with ALS and this one approved therapy, it's looking quite promising. I think what I would say is that I would say there have been a lot of advances in terms of the science, and I would not be afraid of trying an antisense treatment or being in an antisense oligonucleotide trial, because as a part of any trial, there's a safety monitoring committee, and if anyone is getting worse on the treatment, then trials are stopped, and they're stopped early. That's something that happened with the Topamax trial in ALS. People were getting worse on the treatment, and so it was stopped right away. So I think you can be confident if you're in a trial that no one is going to just wait and watch while you're getting worse. That won't happen.
Thank you. In regards to stem cell, you talked about Clive Swenson's trial. Is this for all types of ALS, for fast and also slowly progressing forms, from your thoughts?
You would have to talk with the investigators to, about your specific situation, certainly, but I know at least for the patients that I've referred to him, it seems like they've been open to either rapid or slowly progressive cases. I think you have to have a certain amount of disability, but not too much disability. But the researchers are very responsive. If you just go on to clinicaltrials.gov and type in Cedars-Sinai, ALS, or go to their website. They have a research coordinator, Pablo, who's very quick to respond with questions.
Thank you.
The next question is, are there any effective treatments to restore function for someone with advanced ALS?
Not yet. I know there will be. I'm sure there will be over time. Right now, all of the trials are aimed at trying to slow down the rate at which the disease progresses. But I think particularly with some of these more targeted familial cases, I'm hopeful that that they may offer some improvement for people with more advanced diseases. Definitely.
So the next question is muscle biopsy important for diagnosis?
Yeah, thank you for that
Yes.
question. Usually not for ALS, because for ALS, the EMG clearly shows that it's a nerve problem and not a muscle problem. But sometimes in really rapidly progressive cases, it can be confusing because if the nerve is degenerating so quickly, it can affect the muscle as well. And so sometimes we order muscle biopsies if the EMG is confusing and it looks more like a muscle disease. If someone has a muscle disease, definitely it's very, very common to get a muscle biopsy and important to do that because there can be treatable muscle conditions. Yeah.
The next question is, do you mind sharing your thoughts regarding Prime C?
Sure. I actually just, again, at the International ALS meeting, learned that a large clinical trial will be starting soon for Prime C based on its promise in a phase 2 study, but it's been shown to be safe and effective in slowing ALS progression, similar to Radicava, I think around 35% and help to improve survival as well. And so there will be a phase 3 study. I literally just checked yesterday on clinicaltrials.gov and the sites are not listed yet for where it will be conducted, but it's a combination of 2 already approved FDA medication, ciprofloxacin, which is an antibiotic, and Celebrex, which is an anti-inflammatory medicine, sort of like ibuprofen. And so I think the challenge with any trial like this, where the components are commercially available, is people taking it off label. And so it can be hard sometimes with enrollment, but I'm hopeful that they'll have good success in enrolling, and then hopefully we'll have another approved drug soon to treat ALS. And it's an oral drug too.
Awesome. And the next question was, are you familiar with a drug trial that's conducted currently in Europe only, which is Eloroxine?
Hello, yeah. How do you pronounce that? I guess Eloroxine, I guess.
Yeah, Eloroxine.
Yeah. Yeah, I didn't see anything at the ALS meeting about that. I know that clinical trials are just beginning with this particular drug, and it looks potentially promising. So it's basically a drug that's an antioxidant and anti-inflammatory, and is supposed to help with the nerve growth. But yeah, I don't know for that one, again, if they've got the sites and if it's possible to enroll. But again, just keeping an eye on clinicaltrials.gov and typing in the names of some of these drugs, you'll be able to do that.
Thank you. And this was an excellent session. And, we pretty much asked all the questions that came in. And thank you so much for your time, Cathy. I know this was, okay, another new one that came in was about NFL.
Right.
So
Yeah, and also about I see about the ALS FTD caregiver issues. Yes, I think I highly recommend the Caregiver Alliance. They have wonderful support groups and information. There's some handouts with both the ALS Association has as well as the Caregiver Alliance about coping with ALS FTD and strategies for caregivers. So thank you for mentioning that. I think it's very important to have caregiver support. And I think with NFL. I think the NFL was used in the tofersen trial. And in fact, that's why the FDA approved of it. What we did learn is that with NFL, it can typically be high early on in the disease and then become normal, or sometimes patients, always have a normal level of NFL. So I think for now, it's always going to be an exploratory aim until we understand more of the totality of how ALS patients respond to it. So I think we'll continue to use the ALS functional rating scale, which is considered the gold standard for measuring ALS progression, which I'm sure all of you know because you have it done when you go to clinic, and with NFL being an exploratory. But I think it will definitely continue to be tested because it was helpful with the tofersen study in detecting changes.
thank you so much, Cathy. I really appreciate you taking the time and addressing. We had over 100 live people, and this gets watched by thousands of people from 60 countries when we put up on YouTube. So really appreciate your time and you touching people's lives in amazing ways. And we really wholeheartedly thank you for everything you do.
Well, thank you for asking me. Thank you for all you're doing. I'm very excited about your research as well. So thank you.
Thank you, Cathy.
We're going to let another evening pass on, but we're not going to forget it. It's that time of the day, and I want you to all know that you're loved deeply. So, thank you.
Thank you.